Our next speaker is Dr. Santosh Mahapatra from Odisha. He will say, never say no, dealing with the complex retinal detachment.
Good morning, everyone. Thanks for the opportunity. As you know, the retinal detachments where you have this kind of picture with large number of puckers where you cannot see the disc well, grade 4 PVR. Earlier we were saying, no, this cannot be operated. But now with good surgical instruments and techniques and microvitrectomy instruments, we are almost trying to operate most of the retinal detachments. I'll go ahead with just showing few videos. This is a detachment with grade C previa, but you can see the disc macula well. It has multiple number of tears, but this is a relatively simpler, apart from the number of tears. As you are seeing, multiple number of tears. It can be dealt with complete vitrectomy with putting up a belt buckle, lasering it, and doing a tamponade, which settles the retina at a go. The next case, here you can see the disc is relatively going to be obstructed because the folds of the macula are relatively steep. This is a female which had a long-standing detachment, one-eyed, other eye has become thiacical, and we are just trying to open up the funnel. And you can see here, the vessels beyond the mid-periphery are not seen. The retina is ischemic beyond the mid-periphery. We have tried to do a complete vitrectomy, but still the funnel was not opening. Then we stained it, put some PFCL, gradually the funnel opened, but the posterior pole is still having some membranes which is not allowing the retina to flatten fully. I am trying to remove all the membranes from the posterior pole with a finished loop. Now the retina is well settled and it is tamponade is given. This is the pre-op picture. You can see no clear visibility, and this is the post-op picture. The case 3, here we had traction below the retina. There is subretinal gliotic bands, multiple number of subretinal gliotic bands. Initial staining with the tricot was done. Clearing the vitreous in all the sectors was given. Now the bands are not allowing the retina to settle. So multiple retinotomies were done to remove the bands like this in the different quadrants, because it was almost, the bands were touching to each other in a circumferential manner, which was like a napkin ring, and is not allowing the retina to settle down. So this is the pre-op picture in a B scan, and this is the post-op picture. You can see well settled retina. Next one, this is a case of a 58-year-old male who's had hit with a large mango fallen from a tree. But due to his comorbidities, he has uncontrolled blood sugar, he could not be operated, and a long-standing detachment with the disc is barely visible, there is a large tear inferiorly, and there are membranes all over. So after cutting the central vitreous, gradually the membranes were removed. The big large tear inferiorly dithermized. The membranes in the posterior pole was stained, and they are removed, taking help of different instruments, starting from flute to finished loop, and now gradually the retina is getting settled in the posterior pole. So in these cases, the complete removal of vitreous is very important to avoid postoperative recurrence of retinal detachment. But you can should not hesitate to do retinotomies as and when necessary, and remove all membranes to make the retina settle at the end. So this is was the case like this, all crumpled in the posterior pole, and this is the post-op picture. I think this is the last case. This is a young male who had a detachment in the other eye, operated, but has poor vision because of posterior pole pathology. He had a detachment in this eye where nothing could be done apart from 360-degree retinectomy, and the posterior pole only could be settled after the 360 retinectomy, parallel laser being applied to retina all around. So the take-home message is every complex surgery opens the door to innovations and skill refinement, and it gives you opportunity for your growth. So let us embrace the complexities, and we should not hesitate to operate the complex cases as well and give a chance vision to all patients. Thank you.
Beautiful videos, but ultimate outcome of the vision, how you have found out?
See, I have operated these cases where you don't have any hope, like other eye,
Hope against
non-seeing
hope.
eye,
Yeah.
this is the only eye, so you have to operate and at least give a chance. You should not worry about whatever the postoperative vision is going to have. You'll have anatomical settlement most of the cases, and definitely some ambulatory vision, which is very, very important for the
Exactly.
patient.
Yes, yes. Even if we have a navigational vision, is really good.
Yeah, very good.
Thank you. Thank you.
Yeah.
Sir. Which one, sir?
Last case.
Last one, sir. Mango, yeah. No, no, he initially he went away. When he came back, he had uncontrolled diabetic. Again, we had to wait for a month. He had a history of fallen mango 6 months.
Can we do it or not? Can we do it or not?
Sir, I usually give opportunity even for 200 sugar I operate, but 340 I'll little hesitate.
No, you can always do that.
So
You can
what-
put
yeah.
the patient on insulin
Insulin.
and we can always do
So
it.
Try to control.
yeah,
We can all in
So-
emergencies, we can always do it.
Yeah.
exactly, sir.
Diabetes is there, you put in insulin, now you can always kick it is.
Yes, yes.
You don't have to wait.
For emergency situation, for emergency situation, one can do it, sir. For emergency situation, one can do it.
I
Definitely.
have advised, but
And-
the patient did not come. He thought, let me control the sugar, then I'll come.
Under the
That's
medical
what I wanted to
advice,
convey.
insulin and all, dermatologist, one can definitely in emergency situation, one should go ahead. I mean,